Okay. Yes. Welcome to the TelePT Connections podcast. I'm Daniel Seidler,
I'm Adrian Miranda.
and our very special guest today is Dave Dansereau. Dave and I spoke a couple of weeks ago, and we said we got to do this. So good to have you here, Dave.
Hey, thank you guys. Likewise.
Yeah. I see all your marathon stuff behind you. You're a Boston guy, right?
I warned you. Yeah, I'm a New England guy by heart, and a little bit of a mild obsession with the Boston Marathon. It played a big part in my recovery and my return to practice, and I'm still, if I can get a few more miles in, maybe I'll have one more go at it. But yeah, for sure.
Nice. That's always the dream.
Nice.
Do you still run?
I sure do. Of all
Yeah.
things during the pandemic, I wasn't in training for the marathon this year. Last time I ran was in 2018, but of all things, I joined a beer club running club out of my local community. So we do a lot of philanthropy, but we also just were all looking. Actually, it was founded by another PT in town who was out west and I think had to have been in Colorado, she said, and she went into a brewery and saw there was folks that looked like they had just come back from a run, and I guess it's a thing, and it's like everything else out west, it's more popular. But she brought it here to our little town, and we've donated a lot of food to the food pantry. We try to get involved with different charities and things that are important to our community, and we do a little bit of running, a little bit more than I'd like to, but we do also do a little bit rehydrating after. So it's
That's awesome.
I
Yeah.
love
I
it.
mean,
That's awesome.
I'm sure I'm not the only person to say this, but two of my favorite things, running and
great.
drinking
In
some
fact,
beer.
I just got back from one, so that's why I'm all slicked out. And
Yeah,
I'm
nothing
ready.
better than a nice cold beer after a run.
Yeah,
10K, 5K,
nothing
half
better. Yep,
marathons, great.
yep, for
How many
sure.
Boston marathons have you done?
I did 3 and I did 1 Rhode Island, and there's no comparison. So I've got
Right.
4 under my belt, and actually would have had 4. And I had an injury after in 2000. I ran my last one in 2018, but in 2011, I was supposed to run prior to that. And coming back from training for a spring marathon means you're training in the dark and cold of the winters here, especially in New England. So I was
It's a
coming back
tough
from
one
a
to
long
train for,
run,
man.
20 miles in, and tweaked my MCL stepping over a curve onto a little bit of a snowbank. So actually, I've got a sister who's in phenomenal shape, and I handed off the torch to her. And I was running through.
Nice.
I gotta qualify this by saying I don't qualify. I am not a fast runner. I'm a hockey player, so we don't run fast. We run left to right.
Yeah.
But yeah. So
But you're a local. Did you get in because you're from the Boston area? Or
Yeah, interesting. I've done advocacy. The 3 times I ran Boston, one was for a charitable foundation, Liver Foundation,
Mhm.
and then most recently, the last 2, I was involved with in a group here out of New England, formerly of the American Heart and Stroke Association, called Teddy's Team. Teddy
Yeah.
Bruschi was
Yeah.
a New England Patriot icon here, and he and I share kind of the same in common heart defect that caused our strokes. So
Amazing.
when I was looking for a way back in a team to kind of help build community and find find my way back to back to life after a stroke, I reached out, and I've been working with them, volunteering. Started out with my wife and I. Now my children are older, and we're all involved in some way or another, shape or form. So
That's amazing.
yeah, so I don't qualify by any means, but I do.
You compete and you complete.
I try.
Yeah, right on. You kind of just threw it in there, but and I know it's a huge part of your backstory. You had a stroke. How old
Yeah.
were you?
Yeah, I was 39 at the time of my stroke,
Yeah.
and the term stroke to me, I was not a neurotrained PT at the time. I was 6 years out of clinical practice. I was running my own business at the time, and you know, the term stroke to me was something like a golf term, prior to this. And you see, when you treat in different phases of care, if you're not specializing, you do run into patients that have had all kinds of neuro complications,
Mm-hmm.
stroke, MS, Parkinson's. But it was something that living it and seeing the patient side and coming back from it, I still feel, and that's why I'm still in the game. Now 14 years removed from my stroke. I'm a bit older now, but at the time, having a stroke in your 30s and 40s and 50s, I say, age is now a number. Mine's definitely unlisted now, but I know, I know you and I, Dan, I know before the end of this interview, I'm gonna slip and call you Mike, because you look you look like an old college friend of mine.
That's funny.
So Dan, yeah,
My brother's name's Mike, and he looks a lot like me. Maybe that's it.
It's something that, I, having lived in that world and having come back from that, I saw all the silos and all the barriers to care, and all the, the pressing needs, and especially now fast forward to the pandemic, that was only magnified. So yeah, it's definitely a part of how I practice now. And, if we're connected, Adrian, on LinkedIn, so you probably know I do write a lot about patient engagement, and I use telehealth exclusively for my own rehab. At the time of my stroke, my children were 3, 5, and 7. So,
Mm.
Nice. So who was your who did telehealth with you at the time?
so I hacked it. So I reached out, because this was old school. This was old
What
school.
year was it?
So I had.
I mean, you're 40 now, so it was like.
Yeah, I'm 40 now.
So last year.
Yeah, no, it was 2006. So you're looking at
Okay.
Skype, you're looking at Google Hangouts, you're looking at any way you could get a solid connection. But I was running, I had to make the decision that, I wanted to be back to things that were meaningful to me, and for me to be in if there was a blessing, I could fall back on that, have my clinical training. I was a PT, so I knew what I needed to do. Once I knew I was stable, and they finally found out what had caused my stroke, because it was caused by a congenital heart defect that I went, 39 years with no warning signs,
No idea.
no idea. And, so that led me to really trying to figure out how to do this at home, how to keep, how to keep knowing that I was moving forward, but finding, like, I hacked a Wii board, for example, because I knew it had some sensors, and it could give you really good inexpensive biofeedback. And I just needed to try to, quantify how much my stroke affected my strength, but it really primarily affected my balance. And I, originally was very embarrassed by it, because, I would, two things. So it was a PT that I could fall back on that. And my stroke hero was my wife. My wife's an RN. So my wife did the heavy lifting during my recovery, but also was an advocate for finding out who are the best people to speak to. If you're in clinical care, you can kind of not fast track things, because my recovery and the plan for my recovery and the clouded pathways, I was in what was called this gray area. And that, to this day, this bothers me, because I was in a pathway that they, medical management versus at the time device closure, which now I have a occluder in my heart that has repaired my defect, and hopefully that will ensure that I don't have shunting blood going up to my brain that's not supposed to be up there in clots, potentially clots. So, but we found, that's how I ended up finding the community with Teddy's team. But when you're when you're told, you had a stroke, go back to what you're doing, but you can't lift more than 8 pounds, because you might have another event, because it might cause more shunting through this PFO, and you're a manual therapist, you learn pretty quickly that you can't lift limbs, and it's hard to go back to clinical practice the way you practice. So in the early days of recovery, it was, old school, I guess you would call it asynchronous care now, that, I'd film stuff and I'd send it over to a couple of my buddies. Hey, this is what I'm doing. And, taking pictures of my backyard. I would be engaging my kids. I'd be swinging on the swings. They didn't know I was balancing on an air disc and trying to
Right.
throw myself off balance and restore. And that was just volumes and volumes and volumes of repetitive practice and driving that change I needed, and I would, we started this conversation talking about, running a marathon. I measured my initial gait and recovery in terms of telephone poles because I couldn't run.
Yeah.
I would count in my brain step, because I had foot drop. My left leg just wasn't cooperating. And then I would measure, okay, you know what? I didn't fall. I ran 2 telephone poles. I didn't fall. But initially it was, I mentioned embarrassment. Like I was, real life doesn't stop. We had family that were not able, for their own medical reasons, able to assist at the time. So I still had to manage our home life and children.
Life.
And so I would go to the bus stop and literally wait till all the other parents left, mostly moms. I'm not going to stereotype, but it was mostly moms at the bus stop. And then it was me, and I had the triple stroller, and I wouldn't, I really didn't need it because my kids were old enough, but I needed it in case I stumbled and fell over. It was just my way of just being like, I got this. I got this.
Nothing like a motivated patient, huh, Adrian?
Yeah, seriously, that's an incredible story. First of all,
great story,
awesome.
Dude. And I was going to ask you like how you got into the telehealth world, but you kind of created it and invented it, and mother of invention and all that. I mean, you needed it for yourself. First of all,
I needed it to get that feedback, and I needed it to know that I was on the right path. And there's a lot of fears after a stroke. There's a lot of, and I was afraid. Luckily my symptoms, if you're lucky, they affected my life. I could have drove with an automatic car, but I was afraid. I didn't want my kids to be in the car in fear if I had another event, because we didn't know. We still were trying to figure out exactly why. No risk factors, exercise, no smoking history, no, check you for AFib, all these other potential risk factors. Couldn't find anything. And it wasn't until they dove into this heart brain connection that they discovered that, hey, we got to try to, that let me down. I have a lot of kind of clutter behind me here, but I'm very much into visual reminders. And, it wasn't, in terms of the telehealth part, I was very much, and I mentioned the sensors around the Wii board. It was very much that barrier, and having all the barriers to care in my own case, like something, even before I could elect for surgery, for example, you had to wear a Holter monitor. You had to wear that for like a period of 7 days just to make sure, to rule out that AFib might have caused me to have this stroke and not this defect. So, getting that to me when I wasn't driving and my wife was working, that itself was a barrier. And now we know, fast forward all these years, Amazon delivers all that stuff, but that wasn't there. And it was like these barriers, and then having to, to see other industries like doing stuff in digital. And even back then I was like, why have, and I know you guys did a great job. I'm in the, I would say I'm in the 2% with you guys to kind of get where this is going. And I'll, we see the hockey stuff behind this is used in digital a lot. It's like the term comes up a lot that, pass the puck where the player is going, not where they've been. And that resonates with me because, other industries are following. Again, one more hockey reference, this hockey stick curve, e-commerce, all these other businesses that have just adopted, the way we get food, the way we, reserve for food, transportation,
produce cars and distribute manufactured products,
everything pretty much, except for rehabilitation and medicine.
And you know, and Adrian, I know you mentioned on a previous episode, and it definitely resonated when you're talking about how further along like fitness is in terms of engagement and using these tools and adopting these tools. And I was fortunate to kind of have that background moving before my stroke and even before I became a PT. I was practicing. My original degree is in nutrition. I practiced as an RD for many years before I furthered my education as a PT, but I was, had an exercise science background, personal training, and saw like how quickly things catch on. Yet, especially now that the pandemic has might put a microscope under, our profession in one, but many, it showed that there are a lot of holes that definitely, a lot of areas. And I don't think the book has been, written, but I think we definitely all need to have a seat at the table in our advocacy to make sure that we're included in those chapters.
Yep. It also sounds, first of all, it sounds like nothing like being a patient to learn what the patient experience is like. You're basically telling that story. It sounds like it was a sort of a double-edged sword for you, where it was extremely frustrating, but at the same time, it also opened your eyes to a lot of things and how you could be better in your practice, right?
Yeah, for sure. Yeah, and I'll just say, I'll add to that, guys, that when I had my stroke at 39, when I was looking for community before I kind of found Teddy's team on my own, I said, where do I go? Where do I go? And I was referred to a nursing home, and I was referred to a support group at a nursing home where the average age was like 68 plus. And I'm saying, thanks, but no thanks right now, because I need to figure out how I'm going to get back on the baseball field and coach my kids' team, or get back on hockey skates to go and do something that I like to do, and not, so, that kind of moved.
What about like outpatient rehab centers? Or, there was nothing around you that really was exciting.
Good question. I knew what we had in our community, and I had been doing some work on the nutrition side with some of the practices. And I just, it's unfortunate because now there are more tools coming into these practices, but and then being thrown into this world of recovery, unless you seem to be like fortunate, and I'm, if I had to have this, I'm very blessed that I'm here in a little town in Cumberland around, but we're like 50 minutes south of Boston, some of the best care in the world, including Spalding, and and that's where I eventually had my closure for my PFO. But I knew that my in-town alternatives, I basically knew what they had in their practices, and I kind of knew I already had that in my own home, and minus, I could augment that by having a PT that I knew that needed to kind of see me and get hands-on, kind of like this hybrid model of care now I think we can move to complement telehealth. I think that I found more value in time with that, and with diving in and learning more at the brain. I just realized the volume is just not there in your average 30-minute appointment now in an outpatient clinic. It's just not, and I'll, I hope we can talk about, where I've gone with this with a team to try to solve some of these problems. But right before everything was shutting down during the pandemic, I was fortunate enough to be able to go out to LA for the last International Stroke Conference that was actually in person. And this was February, and things started shutting down a month later in March. But all the best science and all of the research that was coming out of that said the future of stroke recovery is in the home. And for example, Steve Kramer from UCLA, neurologist there, and some of the top docs, they said they've actually studied this, and they said, we've counted reps on the average patient that comes into clinic, and it's 32 reps. And even on the best, the time and investment for someone, and I lived it after, but I used to see in the outpatient setting similar scenarios where I knew the patient, there was a big cost to the patient getting into the clinic. And this is just could be an orthopedic patient. They might need a ride share to get there.
Yeah.
They might wait to see the PT who's double booked, and then they come in, and I'm treating 3 or 4 patients, and I look out, and thank God it's a really nice day, and I'm looking, in that same patient I knew kind of bumped elbows with another therapist in the clinic is still waiting for a ride home some 2 hours later, and I'm like, this makes no sense. They just gave their entire morning up for 30-minute touch points with a PT, and hopefully they got like eyes on them for 30 minutes, but there's just no guarantee right now.
Sounds like accessorate, huh, Dan?
Yeah, I've seen it happen, man. I mean, I've treated patients at like 4 p.m, left the office at 6:30, and the patient is down in the lobby of our building still.
Yeah,
I mean, it's crazy what some people actually go through to get to PT and to get home from a visit. And sometimes the ride never shows up. I mean, that's the crazy part.
Mm-hmm.
Yep. So you guys know, in your state, same thing. We've had
New
big...
York has New York City definitely has.
Yeah, and we're a little town, and we have the same. There was problems with rideshare services and the ride assist, and I just said, boy, we got to start thinking about doing this differently.
So you presented at the Southern New England Rehab Conference, Advanced in Stroke Rehab, right?
Yeah.
Future of Home Stroke Recovery and Prevention. Where will connected health tools fit? What did you do?
Answer the question, David.
Hot seat.
I'm sorry. I didn't study my notes very hard, but they're in front of me.
That was going back to like 2016. So this is pre-pandemic. And, I polled the audience because there was a room full of probably 125 combination PTs, OTs. And I was just seeing like roughly where folks were with adopting digital, and I think, and I posted this on one of my articles on LinkedIn, but so don't quote me on this because it goes back, but I think a show of hands, there were like 2 OTs and maybe 1 PT out of this room of 125 that were even using like an electronic HEP or just some way of, using video to engage patients between visits. And at the time, I had been working with a couple of startups around in the sensor space, and it was more joint performance, and it was just around the time when the elective joints were coming in the orthopedic space around bundle care, CJR, and that type of thing. So I was representing a few companies. So I had come back from a conference where I was very excited because I saw what they were doing in home care and, talking about the future of
when was this? This was around 2016.
Yeah. So I was like,
everyone's doing it, right? Everyone's going to be doing it. Everyone's doing it already.
Yeah. And then so that was that conference, and I was asked to bring in my story a little bit and how it resonated, but I was really trying to get feedback about where we were at, and I've always been engaged about seeing that light bulb come on for patients. And, that's where the power at, telehealth, I really feel like we've lost that touch. And all you have to do is walk through any clinic now and see, especially now that things are starting to reopen, and see how many PTs' backs are to their patients and how many are feeding data into their EMR, their billing beast EMR, that just so they can make it through the day and have a home life. I said, we need to do things, and there's no excuse because the technology is there, but it's just not happening. So I walked away from that conference where I presented, and I said, boy, it's a lot of work to do. And most recently during the pandemic, I said, I was kind of getting an inkling that stuff was happening in pharma. And I know Dan, I shared a little bit about this with you because there were 3 or 4 sensor companies that had luck in sport performance, and they were trying to get over that FDA hurdle to kind of get into the orthopedic space. And I didn't have the tech savvy to be able to, I could have faked it till I made it, but I was like, I'm doing you a disservice. Let me go and jump in and do a little more research. And I found like, here I am thinking maybe there's 6 or 8, performance sensors around turning this damn thing digital, right? So for the podcast audience, that's a goniometer, right?
It's a
right?
A well-used, a well-worn goniometer.
Well-used. Look at that thing. That's yellow.
Is that from like 1920?
Well, no, that's from sitting in my car because I don't use it.
That's what it is. It's an old goniometer.
Yeah.
Not necessarily used.
The carousel of digital progress here.
Watch the YouTube version of this.
You watch the YouTube version, yeah. If anyone, does it? I don't know.
By the way, it's worth it just for.
I think there was like a kitchen timer in there.
Oh no! Hey, if we had time, Adrian, this is the.
Is it voice activated?
This is the first. This is the first rude accelerometer called the Caltrack that really exposed me to the potential for giving patients some form of. It's probably one step ahead of the pedometer if you go that far back, but it was digital.
So I got to interrupt you for 1 second. Did you say Billing Beast EMR?
Billing Beast.
Billing
Beast. Okay. They are a beast.
I think we created a new term.
I think.
But good point in itself. I mean, and we've talked about this with other guests about it being about compliance and billing. I mean, that's what the EMRs are about. So you were talking about devices from
So thanks. So so I thought maybe there were 3 or 4 sensors that around joint performance or joint measurement, and then taking that to the remote phase and getting that data back to kind of look at real world mobility. But then I kind of went outside my comfort zone and saw in clinical, in pharma is where they were doing sort of the biggest, I took a leap and I said, I'm going to go to this conference in Boston, again, close enough that, very expensive to be part of these pharmaceutical conferences. But turns out I was like the only PT at the event, but it was well worth my time. And some of the lessons learned were, there's a lot in pharma going on right now around remote clinical trials, breaking down the clinic walls and the barriers to doing research, out of a university or out of a medical facility, but really, tapping into a more diverse population as well, for some of the barriers we talked about, getting to a research site, et cetera, some of the socioeconomic barriers as well. But I was really, when I found out how many sensors just in every, the term that comes up in these circles is the Internet of Body. It's not the Internet of Things around medicine. It's the Internet of Body. It's really, we have the ability to measure and monitor things for COPD, but in pharma, a lot of it is now pairing a medicine with a device in some cases, because
monitoring device.
Monitoring not only to to look at performance, but optimize medication management, look for try to collect missing data and find out where patients are dropping off, but also to I think going in the direction, a lot of these medicines are getting more and more expensive, and they got to prove that they're worth the value. But one of the things that really hit home for me is every discussion or at these conferences around mobility, and improving that's our space, guys,
Right.
And
who were they addressing it to? I mean, who was listening?
Yeah, no, it's a really good question. It was all the big names in pharma, your Pfizers, your Bayers, your AbbVie's, your, and they were all sharing best practices, but some of the things that I walked away with were the lessons learned in the breakout sessions. And, I'll give you one example. They broke out later in the day and they talked about successes and failures, but I sensed, I'm sure there was stuff they weren't sharing, but I sensed even, you would think your Bayer and your Pfizer and some of your other big, your Medtronic, they're not talking to each other, but their engineers are anxious to get a lot of the innovation there out of lab. But one of the breakout sessions I had engineers at my table, they're giving out, and they broke us out to about groups of 8 to 10. And I'm thinking, I'm hearing people say, oh, low back pain, all different conditions that we're supposed to work as a group to solve. And they get to my group and they hand the card and it's mental health. And I'm like, damn, what am I, like I'm thinking I'm going to get ankle pain, hip pain, low back pain, shoulder. And they start going around and we started to come up with solutions around a digital solution for mental health, and talking about what type of biomarkers can we look at, what type of things that we can do to capture real world data. And we started coming up with some of the typical things, and we were talking about what about diving into someone's social history, and how do you capture whether or not someone's feeling well or being bad? Maybe it's by how much or not they're texting, or it all came back to the phone, and it came back to who's positioning themselves to be in the healthcare space that might not be there presently. And we were talking about, well, who has the potential to monitor and manage medicines, who has the potential to capture facial expressions, who has potential to see how someone's socially engaged. We went on the circle, and we're all coming up with these big names. And the guy's, you wrong. He goes Amazon. And we're like, you think pill pack, you think, and you think of all these acquisitions, and you think whether it works out for them, and that's just one player.
Well, I mean, everything. I mean, it's also, knee braces and ice packs or hot packs or massage devices. I mean, they got a lot of, Amazon has a lot of information on all of us.
So sure. it was eye-opening. And I walked away, joining up with a couple of professional societies that, maybe we can add them in the show notes, because I think there's much more that we can be doing. And there's, this digital health playbook is being written right now by some of the.
So what did you learn? What did you learn that's applicable to the PT profession?
Yeah. So what I learned after that was that, again, the main theme was around mobility, and a lot of these devices, and especially in the case of like MS and Parkinson's, there's a lot of money and research being put into optimizing outcomes in the therapeutics. There's a lot of money in that space compared to where I found there's a lot of deficiencies in stroke, for example, still.
Yeah.
But in everything around mobility, and not really clearly understanding yet how a lot of these technologies and a lot of these care interventions could fit into our clinical workflows. And I can tell you, one of the things I walked away from that conference meeting to a gentleman that I won't even mention the company, but it's one of the biggest pharmaceutical companies. They just pinged me after, sitting, talking over lunch. They said, we want to come back to your clinic, and we just want to talk to you about a few things. And I'm thinking, well, here's me, this relatively unknown PT in a little community outpatient facility. And they followed up, and then we talked workflows for after my last patient in the hour, at the end of the day, they came 2.5 hours later, and we're both like going, we got to continue this. And that ended up breaking off into further discussions around the potential and the lack of ability right now for folks in that space to really understand what we do. Like, they know what's going on in the lab. They can analyze.
You're preaching to the choir.
And so I'm like, we have such value in our knowledge and our skill set, and whether you're a year out or 20 years out, like I celebrated in the pandemic my 20th year, not the way I wanted to leave clinical practice. And I'd been positioning myself to move into this digital space for, at least 5 years prior to that, doing more and more consulting. But I look now as there's this urgency, because there's this pattern. Adrian, maybe you can talk to this, this kind of phenomenon that I'm talking to young grads that are 2-3 years out, and they're just ready to leave this great profession that we have. Mm-hmm. And the model just is not working to for us to be able to use our skill set to treat to our highest level. And technology can help solve that. And it can, I've heard other guests you have on talk about, we should be screening. We should have all that data before they even walk into the clinic for that first eval. Yeah. And the fact that we're still using, the bloody fax machine and double entering and doing all that other BS that comes along with, actually seeing the patient for the first time, all those barriers have to go away,
Yeah, it's true. Totally. I mean, I'm 11 years out, but 5 years in, I wanted to quit. I went to learn programming, and I was like ready to just bail. And I hear, I'm not sure how involved either of you are in like the social media Facebook groups that are like 20,000 with a lot of new graduates asking about all sorts of stuff, starting a practice and quitting. So it's like mostly like this job is underpaying me. Where do I go? What do I do? Any jobs? All the jobs are bad out there. And I don't know. I think it's I don't want to blame academia. I will blame them next year with the fact that I actually interviewed for a university to teach. I taught for, part-time for 6 years. And I was like, well, I'd like to interview, but it's only if you're starting to create electives and courses that are going to give students exposure to telehealth and digital and even software and apps and go beyond just manual therapy and exercise, which I think when I was in school and even my first 5 years out, I was digging into the Josh Cleland articles and the Syriac stuff and all the, Diane Jetty stuff, all the amazing stuff. But then now it's a whole different world. And I don't think that we're preparing the new graduates, and even the new graduates, I'm talking about like people even new professionals are 5 years out and under, right? We're not exposing them. They're not being exposed. I think clinics and reimbursement, we can blame reimbursement, but there's a lot of clinicians out there doing great stuff and awesome stuff and using technologies. And I think part of it is like this weird, we're underpaid. So we don't have enough money to invest in creating a new software app, or maybe dentists or physicians or people in the healthcare fields who are getting paid more can take a part of their income and invest it into this brand new idea. So they're just indebted with 6 figures as well. I am, or was. And you don't have that ability. You can't outsource it. You don't have the time. You're miserable at your 4 patients an hour. But I think if we don't fix it next year, and I think I spoke at the Physical Therapy Learning Institute on the future of education. I said, I'm going to say that we should fix this in a year. 2022, this shouldn't be even an issue,
If we can't do it now, but there's I don't know if you guys happen to, if the FT, I'm going to say this wrong, FT-SBE survey for clinical practices, did you guys happen to, I meant to send this to you, Dan, before to ask, because I did want to bring it up.
I didn't see it.
The clinical practice survey. And I'm like, this is the year. So I'm going through all the items, and it was, there were probably 35 items, and they were going, what are the competency skills? What do you think entry level? And the scale was from doesn't matter to matters utmost. And I'm going, when are they going to talk digital? When are they going to, and I'm going past the survey items, and there was one item. And I actually requested, after I sent it, because I didn't screenshot it, or else I would have sent it to you. Survey was complete. But I did send out a request to the Federation of State Boards, just
FSBPT, right?
Yeah. Better ST. Yeah.
Yeah.
So
FSBPT,
yeah. So, the same agency that you panic when you had to sit and take the exam, right? So it kind of reminded me of the actual licensure test, because it was the same framed up, but it was only a survey after, and there was only one question about where do you see telehealth, telemedicine, and like just one, and not. I was hoping for a little bit more, and I've done some like really great points, Adrian, and I'm, there's 2 universities and 2 colleges in my home state here that I've been engaging with around that concept, and a lot of them, they might not be top, and some of them have PT and OT programs. Some of them just have a PT program, now a DPT. And I said, why, where's the curriculum? When are we gonna, I'll come down, I'll teach a certificate course. Like I feel like any graduate program now in PT should almost have like an ongoing continuing education component that keeps your skill set up, and you should not have to try to, like, I had to go to the Digital Medicine Society to learn digital health lingo, like, and I had to go outside of our group, and the answer I got is, from one of the largest universities here, was that, we want to show our pass rate, if we start, and it's such a time crunch, you have to develop all these other proficiencies. So they're not pivoting, and they're not teaching this new, digital competencies. And because
some are, I mean, in their defense, some are, not as a full course. And what I thought you were going to say is that schools should adopt maybe a course on healthcare or digital health innovation, like even an elective as part of a DPT program.
Yeah.
I mean, I think,
I think some probably are.
So are you saying that some schools have a curriculum, like a course that's telehealth, or is it just invited speakers like David and you do?
Right. That's all I know of so far.
Yeah. So I guess what I'm saying is, like, even if you talk about digital innovations course, it could be 75% a telehealth course where they learn how to assess somebody through video and voice. And then they have a couple invited guest lecturers who are software developers turned PT or people who are in the startup space or anything besides not brick and mortar clinical.
Well, PTs are basically still being trained to work in hospitals and outpatient ortho clinics.
Right. And so like even like
or pediatrics. And that's really like those are the main tracks that almost every school has, right?
Yeah. And I think even something that Baylor did, which was going to like that 2-year kind of fast-paced model, a hybrid model, and 1 year, I think it's a 1-year clinical. I mean, that was pretty forward. And, I think they came out winning. That was like 3 years ago, I believe. And so I think I think PTs are just in general, maybe our nature is just very hard to take change. We're so used to using our hands and being in front of the patient that to change that for the deans and the chairs of PT departments who've been practicing for 25 plus years, I think that's going to be like the most difficult barrier unless the students going in advocate for it or they get less admissions rate, like the PT profession. Yeah. I heard my friend quit PT after 3 years because he was unhappy. I'm not going to apply, otherwise they would have applied. So I think there's just a lot that has to be done quickly, I think. And I think there should be, in this day and age, having actual coursework that gives them this experience. So maybe like, all those clinicals for the DCEs, like the last clinical, that's just impossible. Do a telehealth, like in the institution. Figure out how to do a digital kind of clinic, but expose them to them. Because then you might get half of the batch being really excited about it and just scaling up a telehealth business and reaching people in small communities all over the country. And I think there's an opportunity. I think we don't take it, then it's our fault.
And I think you use the term a year out, and I'm interested why you feel that's sort of a hard deadline. But like, look back to 2020, those 2020 graduates of DPT programs, two of the universities that I say, what did they do for the whole last year of clinical affiliates? And many of them didn't. I mean, that's where I got my first job. It was, my last affiliation, they liked me. I stayed on, learned it was invaluable. I stayed there for a year and a half after and got like an enormous amount of experience in all different phases of care. And I said, were you guys actually trying to pivot and try to get experience and pair with those folks that were actually doing telehealth, and they didn't have an answer. They weren't ready, and none of us were ready. But when you move forward to next year, and if we're still having these conversations, let's go, and there are a good percentage of our group still doesn't know what like Sword Health and all the whole host of others that are doing and the money they're getting to innovate. And it's always it always bothers me, and this is to your point, Adrian, around we should be teaching digital innovation. We should be teaching entrepreneurship a little bit more, because it's always seems when I dive into an innovator's story, it's always seems to be that they came into the clinic looked at the way we were still doing things and said, this is ridiculous. I'm an engineer. We got to do this, do this, do this. And they got their MVP like ready to go, and they have funding. And I'm like, but they still don't understand the workflows completely, but they have the technology solution. And that's where like we have such untapped potential in this space. And why do you think, Adrian, that like we got to move? Like what is unique about by the end of next year?
A number of things. I think it's economically speaking, if we didn't spend 2020 and 2021 preparing ourselves. One, we don't know about this whole economic in the government and not having any money, cash to put into the medical system. Right now, we're printing money, but that's okay. So I think also it should have been done 2020 automatically, but 2021 you have like a little bit of like a buffer for institutions, educational institutions, and even clinics to kind of be like, I don't like it, but let me just figure this out. And so by 2022, that should be kind of, maybe we'll go back to normal. I think hopefully the variants stay out, they stay in India and the UK, and they don't come here. And, the boosters kind of keep us at a normal phase. But I think 2022 is going to be kind of, it takes about 1918 was 2 years to kind of get back to normal in 1918 Spanish flu. So I think 2 years is about the time. Okay. So just hunker down and kind of figure out your stuff. And I think it should be about a year to 2020. Then 2021, it's really fine tuning things. 2022, institutions and clinics as well, not just institutions. And clinicians should be ready to kind of pull the trigger and be prepared to kind of take care of society, so to speak. But because we have tons of data. That's what I kind of mentioned, is that we've done studies on education. We've done studies on admission rates, DEI, technology, telemedicine works. We just haven't actually done any action towards it. And then sometimes when I talk to, done DEI stuff, it's like, you've been talking about this for 20 years, now it's time to kind of do something about it. Yeah. We've been talking about education for 25 years. There's people who've been teaching for like 40 years on that call and said, they're like in their late 60s and they're like, we've had this conversation for 25 years. We have to do something. And I just said, you have data already. Just go back and do retrospective analysis and study the data, big institutions with hundreds of thousands of graduates, and then learn from that data. We're not guessing. So that's why I'm like, 2 years should be plenty of time to kind of, you have this data already. Just go ahead and analyze it. Take a month to analyze it, because we have we have Python, we have R, we have S, statistical methods, research, PTs who are research statisticians, like beyond the amazing, incredible statisticians. I don't think it'll take that long, but to take action, give ourselves 2 years. I think that's pretty legit. That's a pretty good time frame, I think, and it's also to set ourselves up for the future.
You've done some research, you've done some studies, and
I was doing my SCD at Texas Tech, so I went through the whole process of it.
Yeah. Dave, you did research studies in manufacturing facilities, right? Was that like capturing movement, verifying mobility?
Yeah, that goes back to the original. What do you call this? A timer, an oven timer? Yeah. So this goes back.
What is that? Kitchen timer.
What is that? What is that you're holding up?
This is one of the first accelerometers that measured. This was my first launch after I was an RD at the time, and we were measuring, and I was working on one of the first worksite wellness projects that was looking at chronic disease management funded by the National Cancer Institute. It was out of Miriam Hospital here in Providence. And it was one of the first times they actually were trying to look at different manufacturing sites. Many of them have since gone, like names like Polaroid and Kodak. And they were looking at, how do you target the high rates of smoking, physical inactivity, and poor nutrition. And this was one of the first things that resonated with me for like the power of using technology to give biofeedback, because, we were looking at folks that were on their feet all day and they thought they were being physical. They might be in assembly line manufacturing and they were physically tired and fatigued at the end of the day. Really, when you measured how much they're actually physically moving, it was like very minimal, not enough to even reach any of the thresholds for any cardiovascular improvement or disease risk, reduction.
Really? Yeah.
And it was like, giving them the power of actually seeing and seeing that and seeing why that put them at risk, and showing, well, that fatigue you're feeling in your legs is because, like, if I asked you right now to do 5 sets of stands, you probably could do 3 in a minute, but giving them the power to and then we targeted our health message around where they were. So that was like early behavior change. And we looked at exercise or improving exercise as a gateway to improving other things. Like, would you, if you started eating better because you were exercising, and maybe you would
stop. Like if you have a big workout in the morning, you're not going to go out and get drunk the night before and smoke a half pack of cigarettes.
Yeah. So we use that data to, target programs. And I said, wow, that's going back to when, bring a laptop onto a clinical, onto a manufacturing, and then bring and add, this was like state of the art back then. But now, we have these devices that can give us boatloads of data rocketing in the background.
So what applications do you see coming down the pike for, like, related to that, like for real life, right?
Yeah, I think, I think when you take a patient, for example, like during the pandemic, I handled, some of the more difficult patients in our clinic that people like, how are you doing telehealth with someone with Parkinson's? How are you doing telehealth with someone with MS? How are you working with that stroke patient? And, I used this early on, and I kept it because, when a patient's feeling anxious, they're feeling all the fears like that would paralyze anyone. And then you add the fear in some of these patients that already had other comorbidities or were at, had underlying conditions that would put them at higher risk. The last thing I wanted to do is bring them into the clinic. And we made a decision. Some of the clinicians continued to stay and try to continue to see patients. And I led the telehealth effort, and I used this, it was like, okay, let's start simple. Let's reteach how to breathe, because if we're tight and we're panicked, simple.
So Dave's holding up a whiteboard.
Yeah. Get back to basics.
Whiteboard said smart moves, breathe, hydrate. I can't see the word next to it.
Part of hydrating is to, move.
Hydrate, smile, share,
rinse, repeat, rinse,
excellent.
Rest, rinse, repeat. And, at the time I had my hash marks thinking we were going to be kind of, shut down for maybe a couple of months, 14 months later or whatever. But I think that where I see digital, like in the case of a patient with Parkinson's, what if I could remotely assess, and the technology's there, but you guys mentioned on episodes, it's the barriers to who pays for this, because that goes back to some of the conversations I had with the folks in pharma. Like, I asked the question, who's going to quarterback this initiative? Like, who is it? Who's
paying for those remote patient monitoring devices? How are patients getting $400 devices into their homes to do all the things that these amazing devices can do, right?
Yeah. And I think if patients are, and we give up our, with social and everything, we give, if the benefit back, I think patients are more willing to give some of that data. We talked earlier about the Internet of Body. There are innovative insurance carriers, things now that are, reimbursing for, these things. They're, and that's, and the clinical side, that was a lot of where I was trying to see, can we bring some of that pharma innovation into the clinic and get some of these technologies covered, whether you write it through as a remote clinical trial that the patient would know, hey, I'm still getting my PT, but now I'm getting my PT enhanced with a mobility device. And, there's these other whole code set that we're not, and you guys mentioned it on episode, these 99,000 code sets that we're, remote patient monitoring. There's ways around, but we don't have a piece of that. And
on that conversation,
we're not in that conversation. Yeah. And maybe you can do it indirectly through an MD but the ability to remotely see what they refer to as all the data under the iceberg, it's not the tip of the iceberg, but it's not those 3 points in care when I'm physically, whether it be in the clinic or over this, where I'm saying, move for me, let's do a screening, see how you're doing. It's how did they do all those other times with all that data that we don't capture around how they're moving in their home? And that's, I had a patient during the pandemic say to me, if someone with PD, for example, might wait, if they're lucky, be able to see their neurologist twice a year. Yeah. And I talked about this at one of my keynotes. I said, we have patients telling me that they get more data and more feedback from their Apple Watch than their own treating physician is giving them. Like they get that feedback and that ability. And we have the ability now with, state of the art was strapping a sensor on, but now the optical and the 3D and the camera systems that, for tracking, I think if the value that the patient sees for maintaining their independence and knowing if they are electing to enroll in a clinical trial that's remote, that the value, and some of the more innovative folks in that space are rewarding engagement. There's companies like Evidation Health, which I think is doing some great work around, their achievement app, for example, will periodically, whatever wearable you're wearing. So they're using whatever tool you have already, and you're
right, and adapting
opting into an API, and you're saying, hey, nice. Would you tell us a little bit more about yourself? And at any point you can opt out. Like, I'm kind of a geek for that stuff, but I'm like really like the engagement part to me. Like we're the movement experts. So I think we don't do a very good job of prescribing movement. And we don't tap into the tools that could improve that.
David, I have a question. So like, what is your vision, or like, what are you working on right now? I know you're more in the neurospace, I'm assuming, but like, what's your vision, or what are you working on that we'll see in a couple of years from now that'll fix all this?
So when I was doing some early discovery around, like I'd come back from the stroke conference, I was talking to a couple of the folks in university, and they said, you really got to scratch this itch around, wearable. And it goes back to earlier discussion about, we need this early on, not 20 years out of practice, but they turned me on to, at the time, this MIT Spark program, which is like, like fail fast type of thing, like, get ready to present and pitch your idea. I've learned from all the barriers to care that I had around stroke, that's kind of what I want to be part of my legacy in terms of solving a lot of the, like, connecting technology, but not having all these silos and all these barriers to recovery after stroke. So I wish I could tell you exactly what we're doing, but I'm signing an.
You don't have any secrets here, Dave.
I'm sorry. Yeah. Well, I heard about.
Paraphrase it.
Paraphrase it.
And we won't tell anybody either.
Right. NDA compliant paraphrasing.
So one of the things I can tell you that I'm very excited that kind of leads down one of these pathways to what I'm going to be doing with the university as a clinical lead on a project, which maybe you can have me when I have the green light on this particular project. But what I can tell you is one of the things that really gets me up in the morning now is the work I'm doing with another co-founding partner on a project called Enable Us, which during the pandemic, I was already doing research around finding out what happened to a particular stroke recovery app at the time that was put out by the National Stroke Association. It kind of just disappeared. I tracked that they got a ton of funding and then they never launched the app. And I crossed paths with someone who was doing some research, who his name is Michael Garrow, on our Enable Us project. He was doing the same type of research as a caregiver. He grew up with his mom as a stroke survivor at a young age, around even younger than when I had mine. And we were doing similar research, and we were talking about care pathways and the idea of building a marketplace so that we could connect and deliver on a digital therapeutic, the term is kind of used now, around optimizing recovery around stroke. So, we're podcasting now, for example, but we started growing this community like all over the world during the pandemic, because we found there's this whole subset of patients that whether they're, newly, just had a CVA, or they're 20 years out, or, 5 years removed, they were shut out of rehab. And we were sending the message as clinicians, like, come see me 3 days a week to optimize your care and mobility. But then when we shut down our clinics, I had been blogging around stroke for many years, and there were people reaching out to me from all over the country, like, can you help me? Like my mom just, is told that her PT clinic closed, and, she's in Texas. I remember I had my Mass and Rhode Island license. I couldn't help her. And I was trying to reach out to a couple of provider groups to see if anyone, but I don't like to refer blindly. But I found that it validated what we were trying to bring. Like we talked about, the pandemic kind of put a microscope on all these, fragmented, dead ends in care delivery. And this project that we're working on, we're building in the technology tools, where we launched a program out of necessity during this time during the pandemic called the Next Step Forward program, which we're now, the pandemic kind of threw us all, lemons. So we're making lemonade and trying to do our best with, we're still early stage. We're pre-funded. We have a commitment, but we were just on the level of starting to engage universities in clinical research. And we have continued to grow our community during this, and we've interviewed, as part of this fail fast concept, it was a partnership between the university and MIT. That's what took me out to LA. We've interviewed hundreds of stroke survivors. We've looked at, the care provider, the payer, who's our customer. And we found that there's definitely a need, and we know that we're building in coaching and survivors. Some of the, something I've done that gives me the most satisfaction over the last, 14 years is answering questions and being available for patients that are new to stroke, like myself.
Would you say it's like a social network with some plugins?
There's a marketplace component. We're building in our rehab pathways, and we're starting, there's a lifestyle kind of redesign element that has to happen when someone, is sent home with, where do you go when you're told your loved one needs a ramp, needs 5 things, and they have 24 hours to do it, or else they're going to have to go to an alternate care facility where they might have checked and saw that it's not somewhere where they want their loved one to be, but it was the only option unless they could make their environment safe and effective at the time. So there's definitely there's a coaching component. We're building in the care, the mentors are folks like myself that have gone through this, but also providing that person with the right tech tool at the right time. There's a lot of things that are unique to surviving a stroke that are different than working with a new diagnosis of Parkinson's. Once you get your medication right and you keep up, as what we know about the importance of exercise now, which is ultimately very important with any physical limitation, but especially with Parkinson's. In stroke, you might be trying to relearn gait, but you might have aphasia. You might have 5 other items that you have to prioritize. So it's delivering a care entry point that measures, helps manage, and that gets the person back to moving
to your condition as a patient,
at the right time.
Are you familiar with a company named Savaro? They're a telestroke.
Where are they out of?
I think they're originally out of New York or New Jersey. They manage telestroke for hospitals around the country. So, in a lot of community hospitals, it's fiscally impossible to have and they have to have, I believe they have to have a neurologist on staff at all times, and it's cost prohibitive. So they actually manage strokes in communities where it's cost prohibitive to have a neurologist on staff 24/7.
So they're doing the initial triage.
Initial triage. They're even rolling it back to potentially have to do interventions like through EMS, like in the ambulance. And then they'll manage the patient, like, through their care in the hospital.
Yeah.
And I mean, it would be a great connection for this sort of thing when you're ready.
Yeah, definitely follow. I mean, we've done a really great job over the last 15 years or so, decreasing the time to door, early thrombectomy, all the new technology. But along with that becomes because we are improving initial stroke outcomes, which is a really good thing. Yep. There's a longer survivorship period, which we haven't studied. What does TPA do long term? Right. We don't know. We think we know, but there's a lot that life after stroke is one of the largest increase we've seen, while the rates have slightly declined, is the young stroke survivor. And there's a lot of, environmental factors. There's a lot of, things that are happening with our society that have accounted for that. But,
and there's so many things you can do. There's so many things. And I'm glad that you, as a PT, and your team are taking the reins with that. That's amazing.
So we're hopefully I can share more. But one of the things that excites me is I've been working hard at putting potential partners together to actually see one of our first products through in our marketplace. And it combines a lot of the elements I just described, but there's a lot around in the technology space that when it comes to university research and using facilities has been a big learning curve about how that all goes down and what people want and need to be part of that process. So
not easy.
So I try to stay out of the legal, and I say, you want me as clinical lead when we've got it all figured out, I'm ready to go. I've got the motivation and hopefully the skill set, or if I don't have it, I'm going to tell you that I don't know, but I'm going to get you the answer. So
yeah. That's great, man. This has been amazing. We have to wrap up. Do you have any questions for Adrian and or me?
I was hoping you would ask. How much time do I have? All right, so Adrian, I'm very impressed with.
We have -9 minutes.
No,
Adrian,
all right.
I'm kidding. I'm
going to hit you hard here, Adrian. No.
I thought you'd skip me and go to Dan, but okay.
No. So you're right on the hot seat around your the great work you're doing. And I got my little cheat sheet here because I want to make sure I asked this right. I think this was episode 2 of Gross Anatomy, right? Really great job. I love the stuff you're doing, right? Mm-hmm. Because so when you're teaching, and if for the folks that haven't seen it, you're trying to teach about the shoulder to your class, right? Do I have the right episode?
Episode 2.
Yes.
So
yes.
someone
is that the Kung Fu episode?
No. Someone keeps coming back. So this part will probably clear. Someone keeps coming back to one of your students keeps coming back. When are we going to learn about the foot? When are we going to learn about the foot? Now, I think that was really well done. Did that come? And this is kind of a softball question, but did that come from like personal experience with, like, where'd you get that as to put into the script?
Wow, that's a great question. So it's almost it's hard to kind of go back because it's weird. It's like when I create it, it's like a child, I guess. I don't have children, but I'm assuming it's like you let your child go to school. You don't know anything that happens in school unless they tell you about it, right? So so you care about it, but it's not like under your wing 24/7. So episode 2, he's trying to move on to the next topic. He's just a jerk. Like that's his character. But let me think. I don't think so. I don't think that was part of an experience. Listen, a lot of the stuff that's in there, like even the characters are named after people in PT school that helped me pass. Okay. Like Claire was a good friend of mine that I almost failed out of anatomy year 1. I went to Ithaca College. And if it wasn't for her, I would have failed out.
Ironic that you're doing a show on anatomy, right?
Yeah, right. Isn't it crazy? And so so it's an O, and then the 2 Dans are really good friends. And one of the Dans helped me study all through PT school once I kind of got my shit together. Okay. and was like just a good friend. He was always on top of stuff, and he would help me kind of review. And then Maxine was, during my residency, I was just so stressed. She would literally make me, her and her dog would make me food because I would never have food during my residency. And so those are all odes to people. And so the situations, they do tend to be pulled from real life things. But that one was just, we thought it'd be funny if like he would just keep interrupting me and like, can we just move on? And it probably does happen in education. Like I taught for 6 years and mentored, and you know, there's times where can we just skip this? Like it's easy. We get it. But yeah, no, that actually good question. I have to think about it, but no, that was not a personal like thing, but I figured it could be relatable.
No, I
just happened to you. Is that why?
No, it's just, as, practicing clinicians with all the, if we're doing our job well, we listen and we understand what the real problems are that our patients are having or what's important. And I was like, I want, that's the first thing that came to mind. I'm like, I wonder if that was actually someone who really needed to learn that or correct that because it was a family member that was really, but I think it's real well done what you do. And so now you're off the hot seat, and because I have, what do I have? Like a minute left? Yeah, I'm going.
Minus 11, but who's counting?
So I'm going to do my magic wand question. All right. So
awesome.
So Dan, if you could, reimagine PT and wave your magic wand, what would you want to see with what you're doing with your business, and what do you think? What would help you bring back that magic to physical therapy and to the whole patient experience, and how could digital help do that?
Yeah, that's a great question.
That isn't a great question.
Well, number one, if I had a magic wand, is I would get rid of written documentation. Of course, this is a fantasy world that we're talking about, right? But in reality, what I would love to see is audio recording of a session, automatically documented, automatically dictated throughout the whole session, that sort of thing. I'm thinking ideal world. I don't know how realistic any of that is, but everything else we've talked about today, things like having that remote patient monitoring and knowing what's going on with your patient before they walk in the door. I love that. Anang Choksi talked about it a whole bunch last episode, where you basically get a readout of a patient's, not only their imaging, but also their biomechanical defects and strengths and weaknesses, and really have a clear idea of what you're dealing with before a patient walks in, and be able to fine tune that through some sort of automated system. But it has to be, it really has to involve a PT. It has to involve that human element, excuse me, and that connection where you're, the patient I see it as a combination of a hybrid in-person and telehealth. We get so much done through telehealth sessions that, that in-person component is, I think it's less and less important than it's ever been. And I think that's going to continue to evolve. But the point being that, you're there to listen to a patient as a PT, listen to a patient, based on the feedback that they're given by sort of an automated system, and really feel what they want and need, make sure they understand it in a real clear, concise way, and explain it very clearly. Yeah, I think that it really is a hybrid of technology and personal connection, and that therapeutic alliance between PT and their patients still.
Yeah. Well said.
Yeah. Did that answer your question?
Yeah, it did. Absolutely.
Cool. That was a great question. I like having to think about that. Most importantly on all of it, by the way, last component of it is just minimize the administrative side of things. And that's real fantasy land. But on that note, thanks for coming, man. This was amazing. You've got a great story, and I love that you're living it too. You've taken your personal experience and you're applying it to make the world a better place. And I wish you nothing but the best. And I'm psyched to be on this journey with you, man.
Yeah, thanks,
I second all of what Dan just said.
Thank you. I say I'm on the back nine of my career, so I'm trying to make it enjoyable.
Everybody, there's always another chapter as long as you keep writing that book, you know?
Yeah, absolutely.
Dave Dansereau, where can people find you?
Sure. I'm at Smart Moves PT is my website, at PT Coach on Twitter, LinkedIn. I usually that's the first place to hit me up. Facebook and other social, not so much. I tell folks if you try to message me through Facebook, you look for an answer at Christmas and around my niece and nephew's holidays. So try me on. I'm very active on LinkedIn, and that's the best way, or on Twitter.
Yeah.
So
awesome, man. Thanks for coming on. It's been great. Thanks for coming, and thanks to everybody for listening to the TelePT Connections podcast. This has been a blast. Subscribe and keep on listening. Tell your friends. Thanks, guys.
Thank you.
Super.
Bye.
Thank
All
you.
right.